presentation. At, at the end of the presentation, Dr. Zaid will answer any questions that are submitted through the chat function. With that being said, I have the pleasure of presenting Dr. Awais Zaid, who is a physician at Urology of St. Louis. He is board certified in reconstructive surgery, and his specialties include, but are not limited to, voiding dysfunction, urinary incontinence, urologic surgery, and neuromodulation.
Well, good afternoon, everybody. Thank you for taking time to spend the lunch hour with me to talk about a topic that's very personal, impacts a lot of quality of life issues, and impacts a lot of folks. I mean, I imagine somebody personally deals with a lot of these issues or knows of family members that deal with this as well. So that's urinary incontinence as well. Just looking at some of these poll numbers here, it's pretty impressive with the degree of severity that you see in a lot of these symptoms, but also people have tried a lot of these things. This is a ginormous problem. And I think a lot of people don't realize there are good solutions that we have to help manage these issues here as well. So like I said, welcome. My name is Dr. Zaid. I'm a urologist here in the St. Louis area. I'm part of a large group called the Urology of St. Louis. We have some phenomenal providers, and we deal with all aspects of urologic care, both on the Missouri and the Illinois side. So we have a lot of great access points as well, too. And what I was hopeful to do was talk about urinary issues today, in addition to bowel issues as well. It's not uncommon when we see folks who come in with urinary issues to ask, look, is this the way it's going to always be? Do I have to live my life like this? Will I ever get my control back again? Can I ever go on a date? Can I be intimate with my partner? Can I even celebrate with my grandkids? Can I get a job? Can I work in public? I can't talk in public. I feel embarrassed. I have to wear dark clothes because I worry about leaking or having accidents. And then what happens is people end up just staying home. They end up kind of severing their connections because they just lose that desire to want to be social because of the embarrassment, either from the leakage or the smell or any of the other issues that come with urinary leakage as well. A lot of times when people have these issues, they'll often map out where every bathroom is. They'll know, when I go to Walmart, I know where every single restroom is, because if I don't, I'm going to be in trouble, as well. In spite of how frequent and common urinary issues are, about half of people don't feel comfortable discussing it with their doctor, or they don't think that this is something that we can help with, so they kind of just leave it alone. But when you go to Walmart or CVS or Walgreens, when you walk up and down the incontinence aisles, I mean, they have huge aisles just dedicated to urinary leakage. You see all kinds of products, pads, inserts, medicine, supplements. It's a huge problem. And unfortunately, I feel that it's really undertreated and underappreciated as well. So our goal for today is to just kind of do a brief overview of how the bladder and bowel work, talk about different treatment options for specific types of urinary leakage, and then talk about some more invasive options as well. And of course, answer any questions that we have for anybody, as well. So the most important thing to realize when it comes to urinary and fecal issues is you're not alone. There's a lot of people who suffer with this. Conservative estimates put this in about 1 in 6 folks for urinary issues. So that's urgency, meaning when you gotta go, you gotta go. Frequency, getting up at nighttime, and then of course the urinary leakage, having accidents when you're trying to get over to the bathroom, having accidents when you go from sit to stand, leaking. 1 in 12 people have pooping accidents, which is very common and very debilitating. And these numbers actually exceed those with other medical issues that we think are common, like asthma and things of that nature as well. So the upshot of it is you're not alone. Even though people don't feel comfortable talking about it, it is a very common thing that we deal with. And there is a lot of things that we can do to help folks with that as well. So the question that a lot of people ask is, well, what's normal and what isn't normal? Well, the way I look at it is if it's impacting your quality of life, it certainly is not normal. And I think to say that, oh, I'm of a certain age and I should just expect to leak urine, I don't think that's fair to people because we have some options to help them. So certainly when somebody leaks urine or poop, it's not normal. And it can be due to a lot of causes. As we get older, our bladder has a harder time holding urine. There are some scary things that can cause it as well too. Dietary things and medications can cause it as well. Not only is leakage a kind of quality of life issue, which is very important, but it can lead to other problems down the road. There's a higher risk of urinary tract infections, fungal infections, wound breakdown, wound infections, and in addition to all the psychological issues that go hand in hand with it as well too. So it's not normal as well. So symptoms that a lot of people come in with are just frequent accidents. Like, they have no control of their bladder. It's like the bladder's got a mind of its own. When they got to go, they got to go. And, if anybody's in their way, they're going to get knocked down because they got to get to the bathroom. They plan around the restroom. That I find is very common. People are like, look, I just can't leave the house in the morning until 10 because I'm peeing every hour in the morning, or I can't go celebrate in the evenings because the restrooms aren't clean. I don't want to have to use the bathrooms. So their bladder kind of takes over their life essentially. And then what we find is people will change what they drink. They end up self-dehydrating because like, oh, you know what? Water in, water out. So if I kind of cut the fluid, I'm not going to leak as much. Well, the problem with that is it leads to things like UTIs and urinary tract infections and kidney stones. And it's just not great for your kidneys at all. So we don't want people to do that by any means. And then, of course, like I mentioned, when you go down the aisles at Walmart or CVS, you see that these pads, they're expensive. They add up, and it's a big problem, as well. So, like I said, it's not something we have to tolerate. It's something that we can try to optimize, as well. So what's important is when you look at bladder control, it's actually a pretty complicated process. We take peeing and pooping, normally for granted when we're younger, but you can kind of see quickly when it goes haywire, things do go downhill pretty fast. But the upshot is there's basically a connect between the bladder, the kidneys, and the brain. So the brain sends signals to your bladder saying, okay, it's okay to urinate now. So in some ways it helps you pee, but it also puts the brakes on the bladder. So if there's any kind of disconnect between the pathways in the brain and the bladder, that's when you end up with a lot of these urinary issues. And different treatments target different parts of the urinary tract. Some will target just the bladder, some will target the nerves that go to the bladder. So there's different treatments for different people as well. And of course, the kidneys play a role in this. Medications that make you make more urine can make you have more urinary issues, of course, too. But the upshot of it is it's actually a pretty complicated process, and a lot of things have to work in harmony for you to kind of pee a little better and normally. Likewise, with the bowel stuff, it's very similar. So basically, signals from the brain send signals to the nerves, to the sphincter to help it relax so you can pass stool and gas at the appropriate time. So if something does not work well in this sphere, you can also end up with bowel issues as well too, very similar to the urinary issues as well. So incontinence, what incontinence basically is it's the involuntary loss of urine, meaning you don't have control, you have these accidents, you lose your urine when you don't want to lose your urine, basically. And there's a lot of things that cause urinary incontinence. Some of them are scary, very rarely. Things like bladder stones, bladder tumors, infections can lead to urinary incontinence as well. But also, the things that we put in our body make a difference. So things like caffeinated beverages, spicy foods, acidic foods, all these things irritate our bladder. Medications are certainly culprit in some cases. Medications that make you constipated, medications that make you make more urine, like the diuretics and Lasix and whatnot as well. As we get a little older, if we're not as quick as normal, that inability to get to the bathroom in time increases your risk of stasis of urine, but also it makes it harder to get to the bathroom in time as well. And then, of course, we see a lot of issues with cancer survivors when they've had pelvic radiation. It can wreak havoc on the bladder. Even though the bladder wasn't target, you're going to get some collateral damage to the bladder. Pregnancy and childbirth and any kind of pelvic floor trauma, again, whether that's surgical trauma or non-surgical trauma, does affect the control of the urinary system as well too. So whenever I see folks, I say, look, in my mind, there are 3 reasons why you would leak urine. So the first type of leakage is what we call stress incontinence. This is the kind of leakage you have when you cough, laugh, and sneeze. And fundamentally, this is a sphincter valve issue. The bladder holds the urine. The sphincter generally controls the urination. So when you put pressure on the bladder, you don't have an accident. Well, if that sphincter doesn't come together all the way due to having children, diabetes, whatever have you, you're going to have a little leak when you cough, laugh, or sneeze. So that's that first type of leakage, which is stress incontinence. Now, remember, the brain does 2 things, right? It's supposed to help the bladder squeeze, but also it slows the bladder down. Sometimes if the signals don't go to the bladder or the bladder muscle stops working, or if there's a blockage, you may not be getting all the urine out. So then you have retention of urine, which is when you're holding on to all that water, and then you leak because water overskims the dam, so to speak, because your bladder is just so full. A lot of times with retention, folks, you'll have other issues like kidney damage issues, frequent urinary tract infections, and things of that nature too. And the last type of leakage is what I, again, dubbed the bladder's got a mind of its own leakage. This is what we call an overactive bladder. This is when you got to go, or you don't have control, or you have the urgent component to it as well. And this is basically a problem with the bladder not storing urine so well. So this is where it can be due to the bladder doesn't do a great job holding on to urine, or there could be something structural like a stone or a tumor or something that's accounting for this as well. So like I said, so stress incontinence, basically leaking when you cough, laugh, or sneeze, anything that puts pressure on that bladder basically as well. This is a type of leakage that you can fix with different interventions. There are surgical options, there are vaginal insert options, pelvic physical therapy. The Kegel exercises are kind of optimal for this type of leakage because you can strengthen those pelvic floor muscles as well. Retention of urine, basically, like I mentioned, is where the bladder doesn't empty all the way. So things that can cause that are if the bladder muscle gives out, if the nerves are not adequately stimulating the bladder, or if there's a blockage downstream. So sometimes, we get something called a prolapse when the bladder starts to kind of fall through the vagina. So if you have a bulge down below, it can create a blockage. Or if somebody's got a stricture or scar tissue in the urethra, or something sitting inside the bladder as well, too. So that can lead to retention of urine. And then, of course, overactive bladder, that's the when you got to go, you got to go. It's kind of defined as the inability to hold your urine and control the urine as well. So an overactive bladder are the symptoms, but then if you have the leakage, we call that urge incontinence. So oftentimes people who have urge incontinence, when they go from sit to stand up, a big gush of urine. When they're walking over to the bathroom, they'll lose their urine. They have frequent small volume voids as well. They hear things like running water, they're jiggling the keys to get in their house. All these subconscious triggers can make a bladder that's already unstable even more unstable, and you can have loss of urine as well. And then again, the frequency component is very critical. Sometimes people are just peeing, so frequently at nighttime, they don't get any sleep. And, that can compromise other aspects of your daily functioning as well, too. And then you almost feel like your bladder's on fire. So you feel like you never get that urine out. There's always something in the bladder. So that can be a component of an overactive bladder as well. Now, fecal incontinence is the involuntary loss of stool. And again, that can be classified as an urge incontinence, meaning when you gotta go, and you just can't get to the restroom in time to poop. Or it could be just be nonstop lack of sensation, so passive incontinence. Again, similarly, these involve a communication between the brain, the nerves, and the sphincter muscles to kind of do what they need to do as well. So the good news is, the bad news is they're very common, and a lot of people don't feel comfortable talking about it. The good news is there are ways that we can help manage these quality of life issues, and I think it is important at the very least to be educated about these. So I appreciate everybody taking time to talk to us about this here. So when you look at the way we manage overactive bladder and also fecal incontinence, it's kind of a step-by-step approach. And we have wonderful guidelines from the American Urological Association. So a lot of this is evidence-based approaches, which is great. But the first thing is figuring out what's going on. Remember, not all leakage is the same. Some leakage develops because of coughing, laughing, sneezing. Some leakage develops because you don't empty your bladder all the way, but then there's that overactive bladder. So that's the first important thing. Along those lines, it's important to rule out anything more sinister, such as blood in the urine, infection, and all that stuff as well. From there, we start with basic dietary and lifestyle modifications. So like I mentioned, certain things we eat and drink make our bladder angry, make our stool abnormal as well. Certain medications can also be culprit here as well. This is where things like Kegel exercises and what we call neurobehavioral modifications, where you just kind of almost try to retrain your bladder, play a role here as well. And that's important. And no matter what we decide to do, that's always going to be important. It's always important to keep in mind what we put in, if it does impact the bladder. From there, we have the second line options, which are the medications. And there's a lot of different drugs. They fall into two different categories, but these medicines are designed to help the bladder relax. We'll talk a little bit more about these here in a little bit here as well. Then we have the advanced options. So for folks who've made appropriate dietary and lifestyle modifications and where the pills either don't work or the side effects are not acceptable, we have advanced options that we'll kind of delve into in a little bit more detail here. So, like I said, lifestyle modifications. What's critical here is, again, the dietary things. Sometimes simple solutions help people. So diet makes a big difference. Caffeine, spicy foods, acidic foods, alcoholic beverages. Weight loss often helps. Extra weight puts pressure on that bladder, which makes it angry. This is where physical therapy can help strengthen those pelvic floor muscles as well. So I think there's definitely a role for this. And no matter what we do, these are really critical to continue to ensure success of any future therapies down the road. Then we have oral medications, and the oral medications, they're a good option for the right patient, but they do have certain drawbacks to them as well. There are two big families of drugs, and they do have different side effects. So side effects from the medications can be dry mouth, dry eyes, and constipation. There is some newer data that suggests that some of the older drugs, what we call the anticholinergics, can adversely affect memory and increase the risk of dementia in people that are already predisposed to it. So we're trying to be a little bit more careful in using these medications than some of our folks in their 70s and 80s and 90s as well. There are newer generation drugs. So this is a pretty, rapid area of development as well too. That being said, though, a lot of folks stop their drugs. Either they don't work or the side effects are terrible, or it's a combination of both, as well. So it is an option, but sometimes it's limited in what it can accomplish for us as well. So then that leads to the advanced therapy. So remember, the first line stuff is going to be dietary and lifestyle modifications. The second line is the medications, and now we have our advanced therapies. So on the bladder side, there are things like injections that we can do for the bladder, mainly botulinum toxin or Botox. There is something called an InterStim, which I dub the bladder pacemaker. And then there is something called the Medtronic Neurosystem, which is kind of an ankle stimulation that we'll talk more about here as well. And then likewise on the bowel control stuff, InterStim, interestingly, is approved by the FDA for fecal control in addition to urinary control as well too. So when it comes to bladder control, one option that a lot of folks ask about is Botox. We use Botox for a lot of other reasons, muscle spasms in other parts of your body, cosmetic purposes as well. But what Botox is a muscle paralyzing medicine, and we can actually inject the Botox into the bladder. The Botox is kind of injected to the urethra with a camera. And it's basically similar in effectiveness to the medications because it works on the muscle of the bladder and it helps relax the muscle basically as well. Some of the risk of Botox, well, there's always a small risk of infection whenever you put a camera inside the bladder. There's about a 6 to 10% risk of urinary retention when it works a little too well and it makes your bladder fall asleep. So some people have to temporarily catheterize to get the urine out. So a lot of people don't continue their Botox therapies, mainly because it's tricky to do and logistically it's hard to get it done or it doesn't have the intended goals as well. So the next option is something called PTNS or PTNM. And what that basically is putting a little acupuncture needle around the ankle. So you can actually see the needle, I don't know if you can see my mouse, but right around there. And what you do is you stimulate a nerve called the posterior tibial nerve. And that nerve goes all the way up and down the leg and it goes into the tailbone and it kind of connects to some of the nerves that help the bladder relax. So what that involves is basically coming into the clinic, we put a little needle in and we stimulate the nerve with an external TENS unit. This is really nice because it's non-invasive, it's non-surgical, it has really no major side effects. The main downside is the time commitment. So for a therapy like this, somebody does need to come in once a week for 12 weeks and then once a month long-term. So it does involve some time commitment. So for people who have busy schedules or people who live far away and where travel is an issue, it may not be the best option for them. And this is primarily designed to help with urinary control, not so much on the fecal side as well. But it's not an unreasonable option as well. Then the third option is something called sacral neuromodulation, which is a fancy way of saying that we target the nerves that go directly to the bladder through the tailbone. That's your sacrum. That's kind of in the upper, in the small of your back, basically as well. So there's something called the Medtronic InterStim system, which is what I personally use, and I've been using it for multiple years with good results. And essentially, it's been on the market for over 25 years, so it's got a good history to it as well. I'm sorry, sacral modulation has been on the market for 25 years, so it's been around for a while as well. So basically, in essence, what we do is we put a little lead wire that goes into the specific nerve that targets the bladder, and this lead wire will gently send electronic signals to help that nerve relax, so then the bladder relaxes as well. What I particularly like about this approach is it's reversible. There's nothing permanent about it. This is not like, mesh and things that, once it's in your body, you can never remove it. So you do a trial period to see if it helps you out, which is really nice. Usually everything is put in the backside. If everything goes great, everything is internalized. So you're not carrying anything on the outside with you at all. So there are many ways of doing an InterStim. You could do an actual staged approach where you put the lead in your body in 2 separate surgeries, or you could do a quick test in the office or surgical center where you basically come in, we put a little lead wire in your body, and then that stimulates the right nerves. And then you wear it with an external device for about a week or so. And during that week, you let us know if it helps you out, because ultimately you'll drive the ship here, as well. You'll track your symptoms. So that way we can quantify an improvement, seeing if it actually helps you with urinary control. The goal is to aim for at least a 50% improvement in urinary urgency, frequency, leakage, what have you as well. This is nice because this is a really minimal invasive way of doing it. It's done with a local anesthesia. So we just numb the area on the back. So it doesn't require any anesthesia. It doesn't require any special prep ahead of time or anything. So it's not a bad option at all. So there's a lot of different ways of kind of doing an InterStim test here as well. Generally, everything, of course, has risks. Any surgical intervention has a risk of infection, pain, and bleeding, but most folks do pretty well with the InterStim as well. And long-term success rates are pretty, they're very favorable. So about 89% of people actually have positive bowel control afterwards, and then 76% have positive bladder control. And again, that's when you define success as a greater than 50% improvement, which for a lot of people is a pretty big deal, as well. If they get that extra, 2 or 3 hours of sleep every night, that can make a big difference. If they're going through half the number of pads or lighter pads, that's a pretty big deal for a lot of people as well. So the data shows that at a 5-year time period, there is actually durable success, which is good news as well. So the key question is, what therapy is right for each individual patient? And there's no right or wrong answer. It's really the upshot of it. I think the first question is the patient drives the ship on what we do here. That's very important. There are different indications for different reasons, as well. The InterStim is approved by the FDA for people who have an overactive bladder, meaning when you got to go, and you have no control. If you have non-obstructive urinary retention, meaning you can't pee and there's no blockage. So that's a very small subset of people, but it certainly is a big role for it. And it's a game changer for those people, or fecal incontinence. There's a lot of people that could benefit from the therapy. I think no matter what somebody decides to do, making lifestyle modifications is important, no matter what. Looking at the survey, it looks like a lot of people have tried either medications or supplements. So obviously, usually medications are still our first line. And if they don't work, then, we have these advanced options for a lot of people as well too. And ultimately, I think the question to ask is the therapy giving me what I want without the side effects that I don't want? Because at the end of the day, the goal is not to improve the urination, is to improve the quality of life. And if we make somebody's urination better, but we compromise, their severe dry mouth or severe constipation or their memory, which is really scary, you haven't done anybody any favors, as well. So that's the key thing when we look at what we do next. So obviously, we have a lot of folks who've had good outcomes, with this. One of my favorite quotes is actually, it was from a child, but that was a different indication. But the message he sent was, quote, like, "Where have you been my whole life?" Or something like that. Again, it's my 14-year-old child, but still, though, I thought it's kind of heartwarming there. And the goal is to not let the bathroom dictate what you do, is to kind of let you live the life that you want, if possible. So that's kind of what we hopefully aim to offer people, if possible. So that's kind of the upshot of what I had to talk about. I know it's a pretty quick whirlwind tour of a pretty complicated topic with a lot of nuances, but I'm hopeful I could maybe shed some light on this and at the very least try to normalize this, as well, because I know a lot of folks are embarrassed and they don't feel comfortable talking about it.
Thank you so much, Dr. Zaid. We actually have a few questions that have come in, and this is just a reminder to those that are on the call. You can use the Q&A function or the chat function down at the bottom and send those in, and we'll try to answer all the questions as they come in. The first question that came in is, can the neuromodulation InterStim system be used when a patient is pacemaker dependent?
Great question. So yes, so if somebody is pacemaker dependent, you can still use the neuromodulation system. It's well away from the actual cardiac pacemaker, so it shouldn't have any impact there. Of course, you want to make sure that you're safe to have any procedures from a cardiac perspective as well. The other really neat thing with this, the newer InterStim system, this is actually in the past 2 years or so, is the devices are completely MRI safe now. In the past, one of the biggest limitations was people couldn't have any MRI scans with the older generation devices because the leads weren't MRI safe. But as of 2 years ago or so, they're completely MRI compatible, which has been a game changer. It opens up the therapy for a lot of people.
Then the next question that came in is, will this type of therapy interfere with sexual function?
That's a wonderful question, and that's a very important facet of somebody's quality of life as well too. So in general, it should not impact sexual activity. Usually, when you have the interstim in place, it's always running. It's always kind of stimulating the nerves for the bladder. So a lot of times, what people will feel is just like a gentle tugging sensation, kind of in multiple parts, either like in the bicycle seat area, sometimes in the labial or vaginal area as well. But it doesn't get to the level of causing any discomfort from a sexual perspective. Also, after the device has been implanted and somebody's recovered, there really is not any physical restrictions per se to activities. We want people to live their normal lives, swim in the water once they've recovered, take showers, go in the ocean, whatever whatever have you.
The next question that came in is, I have a stent that is placed to deal with a kidney stone. I'm having a lot of issues with urgency and incontinence. Until the stent is removed, is there anything that can be done? I'm on Peridium, which may be helping, but only to a small degree.
That's a great question. Those kidney stents can be very miserable. So for those folks who don't know what a stent is, it's used after any kind of kidney surgery, whether it's a kidney stone surgery or looking up and down the kidney as well. And the stent can kind of cause you to have a lot of urgency and frequency, mainly because it's one of those like foreign objects that I kind of alluded to earlier, like a stone or a tumor, but a stent, it can actually tickle the inside of the bladder and make you feel like you got to pee basically as well. Usually whenever I leave a stent in, the Peridium helps with the burning and it makes your urine turn orange, but it won't do much for the urgency and frequency. So usually for the short course that you need the stent, usually I'll start somebody on a medication like oxybutynin or like a Vesicare type medication. And the only saving grace is once the stent is removed, your symptoms should get better pretty quickly. But because I anticipate it's going to be uncomfortable, I do have people on an oxybutynin when I usually leave a stent in place.
The next question is, does insurance cover any part of the ladder therapy?
That's a really important question. And so the answer to that is yes, fortunately they do. Medicare does a great job of covering things and a lot of private insurances will cover it. I think that's why, when we're working with insurance companies, it's really important to make sure that we've documented everything that we've tried. So usually insurance companies want to make sure that you've tried dietary modifications. And for me, that's a no-brainer. We should do that no matter what before we do anything invasive. And usually they want us to have tried one, if not two medications. So there is a pathway that we work down to ensure that we will eventually get to a point where we don't get a hard time from the insurance companies. But that's something that's really important to our team. So whenever we schedule any of these types of procedures, we always want to make sure that it would be covered by the insurance.
The next question is, I have MS and have bladder incontinence and FI as well as bladder retention, self-cathing on occasion. Would I be a good candidate for InterStim? And can one controller have two leads, one for bladder and one for rectum?
That's a wonderful question. So MS is very challenging. It's one of those disease processes that impacts the urinary system in so many negative ways. What I have found is with MS folks, sometimes you can't pee at all, so you're in complete retention. The other times you basically have no control, so you have severe leakage. A lot of times it's a mixture where you don't empty your bladder all the way, but you still have spasms. So you get prone to urinary tract infections. You get prone to leakage as well, but then it doesn't empty adequately, which is very frustrating. So the limitation with InterStim and MS is it hasn't been adequately studied in the MS population. And the reason, again, goes back to the fact that until recently, InterStim was not MRI compatible. And as you know, as a multiple sclerosis patient, MRIs are very critical to staging and following your disease. So the answer is from a clinical data perspective, there's limited data on MS patients and InterStim. That being said, though, I think this is an area ripe for progress, mainly because I think there's a lot of people who have pathology that the InterStim will help because it is fundamentally a nerve issue. So I do think that InterStim is not unreasonable to try in an MS person, especially now that their MRI is safe. I think is very reasonable. The second part of your question, the fecal incontinence. Now, it's actually the same lead. The same lead actually could help you both with urination and with fecal stuff. So it wouldn't have to be a separate lead. So you could make the argument that, look, well, let's try the InterStim for the fecal stuff, and if it helps you there, great. And if it helps you with the urination, great. So it'd be the same lead. You wouldn't need an extra lead or anything like that.
The next question is, how large is the implant, and is it visible under a swimsuit or leggings?
Great question. So there are two different types of implants. There's a rechargeable implant, which is basically like the size of a small thumb drive, and there's a non-rechargeable device, which is a little bigger, as well. But they actually are both under your skin, so you don't see them at all. You're gonna with the non-rechargeable, you do see a slight little bulge on your skin. There's a little scar line there as well. Usually we try to place it so it's underneath your pant line, so hopefully it would not be apparent with a bikini or with leggings as well. We do tend to leave a little bit, it's not kind of right at the skin levels, it's a little bit buried underneath the skin. So you shouldn't hopefully see the imprint of it with your pants.
Next question is, if I have the InterStim, would I still be taking oxybutynin?
That's a wonderful question. I think that's the biggest thing for me. The most satisfying thing for me is when you help somebody and you get them off their medications. So what we do when I do an InterStim, at least what I do is I actually have the person stop their medications before I do the InterStim trial. So I want to get a clean slate to see where they are. And then we do the InterStim trial and we see where everything is without the medications. And I would say for the majority of patients, we can try to get them off of the medications. Now, there is a subset of people where their symptoms are so severe, they need multiple therapies or multimodal therapies. So sometimes we'll add the medicine back. But usually when I do the InterStims, my goal is to try to get you off of the medications first and then add it back only if we need it. And then with regards to medications, I try to move away from oxybutynin or anticholinergics just mainly because of the side effects that we talked about a little bit earlier.
The next question is, are these detected at the airport in the screening machine and cause security to come over?
That's a great question. So when you get an InterStim implant, you get a card from Medtronic. So that card is basically a medical device card. So that's one thing as well. What I tell people is don't go through the machines where you have to put your hands above your arms, go to the metal detector and let them know that you have the device in place. So then they can do the one and you have the card with you. So that is an important consideration.
What is the effect of various therapies on swimming?
Great question. So with regards to the advanced therapies, so when you look at Botox, assuming everything goes great, there's no effect on swimming whatsoever. You should be able to swim and do what you normally want to do because we go through the urethra there. When you look at that PTNS, the ankle stimulation, similarly, you have a little needle poke, but there's really no restrictions to swimming afterwards at all because it's the tiny little acupuncture needle poke, so there's no incision or cut or anything like that. When you look at the InterStim component of things, during the actual surgical healing process, what I tell folks is to avoid any soaking in water for about 4 weeks. After 4 weeks, once everything is healed up and everything is closed back down again, you should be able to swim and do normal soaking in water, bathing activities without any restrictions.
The next question is, can myrbetriq cause blurry vision?
Good question. So we know the anticholinergics cause blurry vision for sure because they cause dry eyes and that can affect the vision. Myrbetriq classically has been associated with high blood pressure, headaches, and I've had some folks complain of constipation with it. The blurry vision by itself is not common, but what I would worry about is if it's making your blood pressure go higher, that could affect vision and things like that. So I would probably make sure your blood pressure hasn't gone up or anything like that, because that could adversely affect the vision. And again, any side effect is possible with medications too. So it is a possibility. The one benefit of all the medicines is you could stop them cold turkey without any withdrawal. So if you're like, look, I'm not sure if the medicine is A, helped me, and B, is having the side effect, I tell people to kind of give it a 1-day holiday, like a 1-week holiday, I'm sorry. So stop it for about a week or so, and then see if your vision gets better. And then during that week, look out for side effects, improvements, but also see what the urination did. If the urination didn't change at all, it's still equally bad, then the medicine A wasn't helping, and B, it might have been causing some adverse side effects.
The next question is, does Kegel exercises help when Botox is my treatment option?
Good question. So Kegel exercises, let's talk about those. So what Kegel exercises basically are strengthening your pelvic floor. So there's a lot of muscles that that kind of augment the sphincter to help control and support everything. I think Kegel exercises are great. I think there's a lot of urinary benefits, sexual benefit to be obtained from Kegel exercises. I do think the majority of the benefit you get from Kegel exercises is that it helps you with the stress incontinence, that leaking when you cough, laugh, or sneeze. And remember, InterStim, PTNS, and Botox are all designed to help you with the overactive bladder urgency and frequency leakage. So I think the Kegels would give you benefit from the stress incontinence. I think that there still is some role for sure for physical therapy, pelvic physical therapy in overactive bladder, but I don't think the benefit would be as great as with Botox. I don't think you lose much by doing Kegel exercises. In fact, I think there's a lot to gain from it, but I don't know if it would have that, like that benefit that you may see with stress incontinence.
Next question is, what is the difference between the system that recharges and then the non-rechargeable? Are they the same? Do they cost the same?
Great question. So that's a very good observation there. So there's a rechargeable versus non-rechargeable generator. The effectiveness, the success rates, the recovery are basically similar for both. And the invasiveness is basically the same. The cost, as far as I know, is basically similar for both, as well. So I don't think that's an issue there. I think the main difference, and this is kind of a washout difference now, is the rechargeable battery previously lasted longer than the non-rechargeable battery. I believe it's between about 15 years or so. But recently, Medtronic came up with a new battery called the InterStim X battery, which is a non-rechargeable battery, which is rated for about 10 to 15 years as well. So in my mind, the main difference is the rechargeable has a smaller footprint. So it's a little smaller, so it may be a little less obvious, especially in some of our skinnier folks with less tissue on the backside as well. In my bias is I'm kind of more of a set it and forget it type of person. So the downside to the rechargeable is you got to sit, once a week or so on the recharging pad to charge it up. Whereas with the non-rechargeable, once you set it, you can adjust the program if you need to, but you don't have to worry about doing any of that sort. So to answer the question, not a cost difference, not a surgical complexity difference, not a success rate difference. The only difference is it requires the patient to kind of charge the internal device once a week, basically.
The next question is, my mother is 94 and has severe bladder incontinence. She wears heavy-duty pads 24/7, but still has trouble getting to the restroom in time, causing her to have to change clothes. I do not feel that either the meds, due to side effects, or implant options at her age. Would the pins hold more urine than pads? We've been told UTIs are more common with a catheter, but what would you recommend in her case since the incontinence is totally affecting her quality of life?
That's a wonderful question. And, you're 100% correct. That is a very, very challenging situation because we do see some of our folks in their 80s and 90s who have debilitating urinary leakage. And I 100% agree. At a certain time, you get worried that, when you have medical issues or advanced age, surgical interventions do become riskier. So we have to keep that in the back of our mind as well, too. And then to second what you said, a catheter might seem like an easy solution, but it has a ginormous risk for infection. So, and then of course, if somebody has any confusion at nighttime or baseline dementia, if they pull on that catheter, it's going to be so much trauma to the urethral and vaginal and bladder area. So I agree, trying to avoid a catheter at all costs is 100% prudent. In these folks where surgery is not a good option, there's a few things I like to do. So medication-wise, I certainly would avoid any of the anticholinergics. I would consider something called Gemtesa, which is a newer generation drug. It shouldn't have as many side effects, particularly no neurologic side effects. I usually like that as a starting point. Of course, make sure we're not missing anything like incomplete bladder emptying. Some of our older folks have horrible pelvic organ prolapses where they have something called a procedentia. So they might be actually one of the overflow people that we don't want to be missing because that can lead to other sequelae down the road as well, too. I think of all the advanced options, though, if feasible, I think that PTNS is a safe option where we have them come into the clinic and we can stimulate the nerve. That doesn't require any invasiveness. There's no anesthesia involved. So that would be an advanced option that one could consider. And I do consider that for my people with advanced age or multiple medical issues as well. With regards to the pads, yes, the more moisture you have in that perineal or vaginal or pelvic area certainly increases the risk of infections. It's just a moist environment, it's a breeding ground for bacteria, increases risk of fungal infections and yeast infections as well too. And it does increase the risk of wound breakdown and sacral decubitus ulcers too, especially if somebody's not very ambulatory. So it is important to try to keep things as dry as possible. So unfortunately, changing pads frequently is an option for that. They do make external urinary collection devices. They're not perfect, but it's basically like a device you put on the outside and it kind of suctions the urine away. So it kind of wicks it away. They are a little cumbersome, but that is something that, some of my folks have had limited success with too. So it's like an external female catheter, not the same thing as an internal catheter, which again, I would try to avoid at all costs.
Next question is InterStim a good option for someone with mild symptoms?
Great question. So I think the most important thing, right, is how much it impacts your quality of life. And I think the way I look at it is there's not much to lose by doing an InterStim, as well. If you're at that point where it's mild, but mild is different for everybody. I have people who get up once per night, they're miserable. I have people who are getting up like 3 or 4 times and they're okay with it, right? So I think the first question is how much is it bothering you and how much is it impacting you? And if you're like, now that I think about it, it seems a little mild with regards to the number of pads, but it's always on the back of my mind. I just can't, when I go into the store, I have to find out where the restroom is because I know when that urge hits me, it's going to be a disaster, or I'm afraid to travel, or I'm afraid to be stuck in rush hour traffic because I don't want an accident. I would say it may not be that mild after all. If on the other hand, you're like, it doesn't really impact me, it's there. There's no harm in waiting. Things may progress, things may get worse, as well. I think the other thing to keep in mind is the side effects of medications too, so if you're like, well, it's mild, I want to try a pill, the side effects sometimes may trump the bother from the urination. So the constipation may be worse than what you have. So you'd always keep that in mind when you're looking at urinary symptoms too.
Another question came in. I have tried everything that you have mentioned, but without much luck. What now?
That's a very challenging situation there. So I think when people have tried everything, the key question is, was it done well? Not to say this facetiously, but InterStim is a surgical technique, and every surgical technique needs to be done appropriately. If you give the wrong tool to the wrong mechanic, you may not get the best outcome. So that's the first thing I'd want to know. The second thing is, I'd want to make sure that you had the right diagnosis to begin with, right? Was this an urge incontinence picture that was treated with a sling? Well, that's not going to help. Or vice versa, was it somebody who had an InterStim put in for stress incontinence? So it's important to know that was done appropriately, because it goes back to the diagnosis box. The third thing I'd want to do is rule out anything scary, right? If somebody has symptoms recalcitrant to all these interventions, well, maybe there's something else going on. Is there a tumor in the bladder? Is there a stone in the bladder? If somebody had a mesh surgery many years ago, has that mesh eroded into the bladder? So I do think a further workup is required. In these situations, when somebody has had symptoms and haven't responded to any therapy, what we recommend are 2 big studies to look at the urinary tract. The first is something called a urodynamic study, and the second is a cystoscopy. Cystoscopy, as you probably have been through, it's basically an anatomic evaluation of the urinary tract, and the urodynamics tells me how the urination is working or not working as well. And then likewise, again, overflow stuff comes into play too. So I think it's very frustrating when nothing works, but you want to make sure it's done by somebody who is technically savvy in doing it, and you want to make sure you're not missing the fundamental diagnosis either.
The next question is there anything that you can do to not get so many UTIs?
Urinary tract infections are frustrating. It's something we see a lot, and when I tell my folks when I see them for a UTI, is in urology and just in medicine in general, we're missing a big piece of the puzzle. Like, I'll have people who sit in a diaper all day, they don't get any infections, and I have people with immaculate hygiene who get a lot of infections. So there's something that makes some people just predisposed to UTIs. So my approach to UTI is kind of a multimodal approach. So, we start with basic evaluation of the urinary tract, make sure there's no blood in the urine, make sure there's no stones or anything, make sure your bladder is emptying all the way. Hydration is really critical. In our postmenopausal people, we look to see if they have any vaginal atrophy or vaginal dryness because an estrogen cream can help with that as well. Constipation prevention is really critical too, because whenever you have a bunch of poop by the rectum, that can, impact the vagina and the bladder as well too. In people who find UTIs associated with sexual activity, what you can do is called a postcoital antibiotic. So around the time of sex, you can have a tablet of antibiotic to minimize the risk of infection. But by far, hydration is really critical. Not holding your urine is critical. Constipation prevention is critical as well too. And then of course, everybody talks about wiping from front to back and things of that nature, which does help. Avoiding after sexual activity is important. The data is not that strong on it. People ask about cranberry supplements a lot. The cranberry supplements is a mixed bag. There's mixed data. I don't think there's any harm in doing it. And there's actually a lot of products that can also help with UTI prevention too.
The next question is, I've taken Myrbetriq for years. For the most part, it is effective, but the cost is exorbitant. Are there other meds that are as effective and less costly? Or when may the cost of Myrbetriq come down?
That's a great question, and so that's the problem with the newer drugs. So there's two families of drugs, the anticholinergics. Those have been around forever. Those are there's generics and things of that nature. Those are the ones that have dry mouth, dry eyes, constipation, and memory issues as side effects. Myrbetriq and Gemtesa are the two newer drugs. They're called the beta agonists. And the problem is they're still not generic yet. So Myrbetriq has been around long enough where I think we hopefully will see a generic version soon. What we have found, and I have limited experience with this personally yet, but what I have found in talking to some of my colleagues is if you work with the right pharmacy, like a specialized pharmacy, sometimes they can work to prior authorize the medications that the big box pharmacies may not necessarily do. So usually, we work with certain pharmacies in the St. Louis area that can be helpful in that, in that area. So we try to get it prior authorized. But you're 100% correct in that sometimes the cost is prohibitive, and again, everybody's got a different threshold for that. And sometimes, the cost and the benefits of the medication may be kind of outweighed, and considering an intervention may make sense. But trying to work with a specialty pharmacy where they can try to prior authorize it makes sense as well. I mean, in some cases you could consider anticholinergic. Sometimes I have no choice and our backs are against the wall. Again, that would be a consideration. Those are universally covered and they're cheap, but they have those side effects as well.
The next question is, how do you determine after mesh surgery, 9 years later, if it has eroded into the bladder?
Yeah, that's a very scary concept, or a thought, as I've seen that personally, where the mesh has kind of made its way where it shouldn't have made its way as well. When you look at post-op mesh complications, there's a few symptoms that raise red flags in my mind. So things that I get worried about, number one is any vaginal bleeding or vaginal spotting, pain with sexual activity, or discharge from the vagina as well. Any frequent urinary tract infections raises a red alarm to me. Blood in the urine, whether it's microscopic or if it's blood that you're actually seeing, are also reasons that I would say you should be evaluated to make sure there's no mesh erosion as well. The way that we check for mesh erosion is a cystoscopy, which is a procedure we do here in the clinic. We put a small camera inside the bladder while you're awake, and we take a look around the catheter, around the bladder, I'm sorry. It's like having a catheter put in. So that's really the most definitive way to make sure there's no mesh complications, along with a pelvic examination to make sure it has not eroded onto the vaginal side as well too.
Do cranberry pills twice a day help to prevent these problems?
Good question. So from a urinary incontinence or overactive bladder perspective, not so much. In fact, sometimes the acidity in the cranberries can be a little irritating to the bladder. From a urinary tract infection perspective, it's a mixed bag. There's some data that suggests that it helps. Some studies that don't show it makes a big difference. What I tell folks is if it's not cost prohibitive, if it doesn't bother you, it's okay to take it. But it's not a magic bullet by any means for UTI prevention. And it certainly is not going to do anything for the urinary symptoms per se.
What are your thoughts about reusable, absorbable undergarments for moderate leakage?
I think that's fine, as long as you're not staying in a wet undergarment for a long period of time. Something that's breathable is always nice as well. But the key thing is just not to be soaked in wet, like in a wet environment for a prolonged period, because that's when you start getting those secondary effects like the wound and the skin infections and the fungal infections as well. So frequent changes and keeping it clean and dry, I think, is reasonable.
My husband had a prostatectomy a number of years ago. He does well during the day at work, but at night when he comes home, he begins having multiple stress incontinence episodes. Is there any specific therapy that might help?
Yeah, that's a great question. So that's something I'm very passionate about too, is male urinary incontinence. So that's the other area I specialize in too. So the answer is yes. Similar to our cancer, female survivor patients who've had radiation, our male survivor patients, whether they've had a surgery to remove their prostate or radiation, can have all kinds of urinary symptoms and leakages. And one of the types of leakage is a stress incontinence, because that sphincter may not be working as well as it was before the surgery. So the answer is yes, there are two great products for that. The first is actually a male urethral sling. The second is a male artificial urinary sphincter. So those are both great products, and those are things that we can certainly help out with as well. The one thing in the post-prostatectomy leakage population that you always need to rule out, though, is any scar tissue that may have developed. If somebody either had radiation or surgery, very rarely you can get scar that develops at that connection between the bladder and the urethra where the surgery was done or where the radiation was targeted. And that can lead to that overflow type of leakage. So the answer is yes, there are wonderful options for men. And those are some of the most grateful patients, because those can significantly change their quality of life too, just like our overactive bladder people too.
The next question is, what causes you to urinate without knowing you are whenever you're fast walking for exercise?
Yeah, that's a good question. So to me, that's a form of a bladder spasm. So what's called insensate loss of urine. You don't have that sensation. And, the way I piece it together is, when that urine is kind of moving around in your bladder, it can kind of tickle the funnel of the bladder called the bladder outlet, where there's a lot of different nerve fibers and receptors there. And just irritating that area can make you basically have a spasm of the bladder, which just leads you to have a big gush of urine. That's the same reason why, at least in my mind, why some people, when they go from sit to stand, like that position change and they have a big gush of urine, it's a similar type of leakage there, as well. So that's how I try to rationalize it in my mind, at least. So it's basically stimulating in a bad way that bladder neck. And kind of going back to one of the other questions, that's the patient who had the person, I'm sorry, who had the stent in place. That stent, the curl rubs up in that same area, and that's why it can give you that urgency and frequency component, because there's a lot of receptors at that bladder neck.
The next question is it common for a 68-year-old male to get up 2 to 3 times per night to empty his bladder?
It can be. It can be common. Doesn't mean it has to be acceptable. So in men, the difference is the prostate comes into play here, as well. So when you start looking at enlarged prostate, symptoms can be what we call nocturia, getting up at nighttime, slow urinary stream, lack of pressure, and complete bladder emptying. So the answer is not uncommon to see that, as well. And like I mentioned, at the get-go, doesn't mean that we have to accept it. So there are medicines that we can do that can help with the urination in men. So things like Flomax or daily dose Cialis or finasteride are all options that we have that can help somebody empty their bladder a little better. But for some people, the urgency and frequency can also come into play. So then we start thinking about these options like Interstim or Botox or medications like Myrbetriq or Gemtesa or the anticholinergics as options too.
Another question is, do you have any research as to why my bladder is more active at night when I'm trying to sleep? I don't have as much problems in the day, but at night I might get up 8 times.
Yeah, that's a very frustrating situation. So there's a few reasons why somebody can have isolated nighttime urinary symptoms. So the term for that, at least the term that I use, is something called nocturnal polyuria. So nocturnal is nighttime. Poly is more than one, and urea is urine production. So NPU or nocturnal polyuria can be due to one of a few things. And some of them you may not even have thought of, as well. So number one is anything you drink right before bedtime has got to make its way out. So water in, water out. So you want to try to limit your fluids ideally before bedtime. Not to say you should dehydrate yourself, just shift the fluids to earlier in the daytime. The second thing is if somebody has any swelling in their legs, all that fluid that accumulates overnight when you lay down flat, the gravity is kind of during the daytime, the gravity is making it all pull in your legs. Well, at nighttime, you're laying flat, so all that gets reabsorbed with a big gush of fluid all at once. So that's the second reason. The third reason that you have to keep in the back of your mind is sleep apnea, which, I know it doesn't seem to be connected, but it is. So people with sleep apnea, they develop nocturnal polyuria. So if you or your partner snores at nighttime, or you wake up gasping for oxygen, or you just don't feel like you get good rest, well, that could be due to sleep apnea. So usually we recommend a sleep study for something like that as well too. And then rarely things like heart disease, heart failure, and kidney disease can also account for that too.
Another question is, once these symptoms start, will they ever go away on their own with diet and Kegel exercises?
Yeah, that's a tricky question. So, and that's an important consideration when we look at these therapies. They don't treat overactive bladder, they manage it, which is an important consideration. I think going back to your question as to whether they get better, I think the key question is, what's the cause of it? In that person who had the stent in, that's going to get better, of course, as well. In somebody who has diabetes, and they have high sugars, if they can get their sugars under control and they're no longer dumping a bunch of sugar in their urine, it may get better. If somebody has a stone or a structural cause, it may get better as well. I do think, though, in a lot of people, if they have some urgency and frequency, it generally doesn't spontaneously get better on its own, and it may progress a little bit as we age. Now, there's different levels of progression, right? If you go from peeing once at nighttime in your 50s to 2 times at nighttime in your 70s, that is probably an acceptable progression. If you go from peeing once at nighttime in your 50s to leaking urine at nighttime and wearing pads, that to me doesn't seem like a very acceptable progression. So the answer is yes, to a certain degree, depending on the cause of the leakage or the symptoms.
Okay, the next question is about medical management. What about Gemtesa? Does it have lesser side effects? Example, constipation, dry eyes.
Yeah, great question. So I do think it does. So Gemtesa is what's called a beta agonist, as I mentioned before. It's different than the anticholinergics. So the main side effect that I counsel people about with Gemtesa is headaches. There's about, I think 13% of the people had it in their clinical studies as well. If you look at the package insert, though, they have all the side effects listed too. So constipation is on there, dry eyes is on there as well. But most people don't experience those, whereas like with the anticholinergics, up to over a third of people are going to have those side effects. So I think Gemtesa, at least of all the medicines I've seen so far, tends to have at least the cleanest side effect profile. Myrbetriq is generally well tolerated. The one thing you have to watch out for that is it can make your blood pressure go higher. So it does require you to kind of monitor your blood pressure.
All right, well, perfect. Well, thank you, Dr. Zaid and Urology of St. Louis. And thank you to everybody who joined and sent in questions. Well, sorry, it looks like one more just came in. What about Vesicare?
So Vesicare, is basically one of the anticholinergic medications. When you look at the data between the different anticholinergics, one is not necessarily more effective than the other, although different people may respond differently. I think the key thing is side effect profile. I still, counsel people that they're going to still have the similar side effect profile to be mindful of: dry mouth, dry eyes, and constipation as well. But again, for the right person, Vesicare is still not unreasonable. It's just that you do be mindful of those side effects as well. But certainly if the concern is for dry eyes or constipation, I would say that Vesicare would be culprit in that situation.
Okay, so now it looks like that was the last question. But again, I'd like to thank everybody for joining and for Dr. Zaid for taking the time to educate us. You can contact the office at 314-567-6071. And Dr. Zaid is at 3 locations throughout the greater St. Louis area. And we look forward to working with you and finding the right treatment options for you. Thank you again.
Thank you so much for your time.